So today I'll be talking about sleep and obstructive sleep apnea, how to screen, how to diagnose, and how to manage. This becomes very important, especially just 2 days back we had Yoga Day, World Yoga Day, and there we learned the emphasis was on the connection between or the yoke between mind and body, and for the best connection is that our body needs a good sleep. It needs a good time to rest so that this connection is well maintained. So what we'll be discussing would be an introduction to sleep. What is sleep? Why is it important? And what are stages of sleep? Normal sleep pattern, the sleep architecture, structure, how it contributes, what are the factors that contribute to poor sleep, changes in sleep in different body systems, especially targeting cardiac system, and consequences of sleep deprivation. And sleep deprivation is not something that we used to have while we were preparing for exams. Sleep deprivation is something that happens day to day with the obstructive sleep apnea and other apneas. So what is sleep? Sleep is a dynamic and a very regulated set of behavioral and psychological stages. That means it has certain fixed set of changes that occur, and if they do not occur in the same sequence or they do not occur for the same time or period, then it affects the health and the well-being of the person. So it is a known fact that people who sleep for more than 7 days are healthier and they live longer than those people who sleep for less than 7 hours a day. And this is particularly important not only for our patients but also for us, because as a cardiologist, our sleep is often interrupted by phone calls, by the thought process that still goes on while we are sleeping. And many of times we have to get up and attend to emergency calls. So the earliest and the largest effect comes of sleep deprivation is on the central nervous system or the brain. So how to get a good night's sleep? There are certain rules. Basically, we are designed to live in caves, in forests, in wild areas, and without artificial light. So therefore, we have our circadian rhythm, which is regulated by sun, and then by sunset, we should start having a dose of serotonin, which should go high, and therefore we should start falling asleep. So maintaining a regular bedtime and awakening is important, because if we disturb the circadian rhythm every day, it is not going to give us a good night's sleep. So we have to have a certain rhythm which we follow daily. And second is that we have to mimic sunset by keeping our bedroom dark and quiet and at a comfortable temperature, so that the body understands that it is now night time. And this is very important with the white screen or the white light that comes from the mobile lights or that comes from laptop screen or TV screen, that makes our brain think that it is still daytime and it does not allow us to have a sleep. Alcohol, it can make us fall asleep very fast, but then that sleep is not a deep sleep, and we often find that those people who consume alcohol, they get up early in the morning the next day, and therefore this sleep is not complete, and often these people need to complete their sleep cycle by sleeping during the next day noon. Smoking or any kind of any stimulus like coffee or caffeinated beverages or tea before bedtime, particularly an hour before bedtime, it can affect the sleep, delayed sleep. One should not exercise within 3 hours of bedtime, because again that results in a hike of it reverses the serotonin levels, and therefore we find it difficult to sleep. And the bed and the bedroom should be away from TV or any mental stimulus thing which can hamper our sleep. So the stages of healthy sleep, the stage this is what is the ordered behavior that happens. We have stage 1, where the body starts to relax, starts to fall asleep, but it is not yet fully asleep. And this is the first stage, and this comes in the first 30 minutes to 45 minutes of sleep. And this comprises of only 3 to 8% of the total sleep. Stage 2 is where brain slowly has a stable and light sleep. But here again, it has some places where the person can be easily awakened. But this comprises the largest part of our sleep pattern. Then we have slow wave sleep, or the stage 3 or 4 sleep, where actually the body and tissue restoration happen. This is a deep restorative sleep, and this is where whatever we have learned, it starts to become permanent. And this is followed by REM sleep, where actually it consolidates the memory and the learning, whatever has happened in the day. And here lies the importance that if we are not getting adequate REM sleep, our memory is going to be hampered, our learning is going to be hampered. And why this happens, we will be at a loss. So the sleep architecture, it is divided into different stages. The first stage, stage W, or the stage of wakefulness, that is the earliest stage of sleep. It fluctuates between a feeling of awake and alert to drowsiness, what in Hindi is called as Unidapan. We experience strange, vivid sensations, some hypogenic hallucinations where we are going into sleep and coming out of sleep. So the common examples include that you are falling, or you are hearing someone's name, or you are floating on your bed, or your bed is floating up. So this can happen during this stage. The next stages have different subcategories also. The NEREM sleep. N1 is where the transitional stage from wakefulness to sleep, actual sleep happens. The brain and body, they begin to relax. Muscles can have more jerking or twitching movements. Here again, the person can be easily roused from his sleep, and most person spend just a few minutes into this, and they move to the stage 2, which is N2. And here the breathing, the parasympathetic system, it takes over. The breathing and the heart rate slows down, becomes more regular, and body further relaxes. Again, this stage lasts for 10 to 25 minutes. It comprises of almost 50% of the total sleep time. Next is the N3, which is also known as the slow wave or the deep sleep. Here, there is lowest heart rate, blood pressure, and respiratory rate. And this is what is restorative biochemical changes here, they occur. This is the one which keeps you young and prevents you from getting old. Here you find that the person is difficult to rouse. There is no noticeable eye movement, and therefore it is NREM sleep. And this is around 20 to 25, a quarter of the total sleep. So this lasts around 20 to 40 minutes. But this is where your thoughts, your learning, it all becomes a consolidated thing. And the final stage is REM, with the rapid eye movement sleep. Most dreams take place, and therefore probably I believe that the eyes are moving to and fro to catch whatever is happening in the brain as if it is seeing. It occurs roughly every 90 minutes, so it repeats, but this is very important stage, and it occurs in cycles. So it can have 10-minute cycles, and they can, with deep sleep, can prolong to around 20 to 25 minutes in each cycle. It occurs after stage N3 in the first part of the night, and later on it directly catches after the N2 stage. And N2 stage, as we know, is the most occurring stage in sleep. And this again accounts for a quarter of the total sleep time, REM sleep. And this occurs late in the night, and it occurs before we are getting, so it occurs in the mostly in the mid period of our sleep. The sleep structure, sleep cycle follows almost the repetition of these stages. So awake is around 5%. Stage 1 and 2, they occupy around 50% of the time. And stage 3 around 25% of the time, REM around 20 to 25% of the time. All these, one cycle, it usually is around 90 to 120 or 80 to 110 minutes. And there are such 4 to 5 cycles that happen every night. The different contributor to poor sleeps, we have already discussed and understood that alcohol, though it can cause you falling sleep early, but it does not give you a good sleep. Same goes for the shift work kind of thing, or high heavy bedroom lights, screen time, white screen, coffee, and the temperature. The changes in sleep with different system, central nervous system, there is increased parasympathetic tone. Therefore, our heart rate and the respiratory rate and the blood pressure decreases. There is withdrawal of the sympathetic tone. The cardiovascular system, it has decrease in heart rate, decrease in cardiac output, almost associated 10 to 20% fall in blood pressure. Anything higher than that would label us as a steep BP fall that we notice in ambulatory blood pressure monitoring. Respiration, ventilation also decreases. The drive for respiration, it decreases. There is the responses to hypoxia and hypercapnia, they decrease, and these can be pathologically be responsible for a central apnea syndrome. The upper airway narrows as the tone decreases, and this can, especially in males, it can result in some snoring, and some snoring like 5 apnea spell or hypoapnea spell in a R are considered to be normal in males, and postmenopausal females, they also have this similar thing happening to them. And then we see parasympathetic manifestations in gastrointestinal or endocrine or renal system as well. The consequences of sleep deprivation, they mostly they come from the studies that have been done on our armed forces personnel. There is decreased alertness, increased irritability. There is lack of concentration and judgment. There is decline in productivity and the higher risk of both anxiety, depression, accidents, mechanical accidents, obesity, cardiovascular risk, type 2 diabetes, and then unintentionally falling asleep. I have a patient who had fallen asleep while he was driving his scooter, and this has happened twice or thrice, and he had an accident, met an accident, had fracture. So this is how the sleep deprivation, he's a Pickwickian syndrome kind of thing, OSA person who had this thing. So sleep disordered breathing is what it is not consequence of not breathing during sleep, that is apnea during sleep. And the basics are that any type of disordered breathing which is associated with sleep, and this includes, it's an umbrella term for many things. It is primary snoring, which may be innocent. It can be obstructive sleep apnea, it can be central sleep apnea where the stimulus do not work. It can be kinestokes respiration where the stimulus work, but they work alternately with a very hyperstimuli, or overlap syndrome where all these things, OSA and chronic obstructive pulmonary disease, can overlap. Nocturnal hypoventilation and a composite of everything which we call as complex sleep apnea. So it's an umbrella term that has central apnea or kinestokes breathing or nocturnal hypoventilation, but major part is always made by obstructive sleep apnea. This is most common type of sleep apnea. It may be caused by a partial or a complete collapse of the upper airways or the tongue obstructing the airways. It is characterized by repetitive pauses. So it's a train of snoring, then apneic spell, then it's like train that it reaches a station, then the train starts, then reaches a station, and that thing, and this can occur. The definition requires that apnea or hypopnea spells should be documented more than 10 seconds. So that is what is need to be remembered. And more importantly, the individual usually is not aware of this problem. So one has to inquire it from the individuals or the patient's spouse, that whether this person snores and is there a certain this station train and station kind of thing is which is happening. The central sleep apnea, it is because of the lack of drive to breathe, and it results in repetitive pauses and pauses in breathing without any effort. Whereas in OSA, there are the pauses need, and they have a need or effort to breathe. Whereas central apnea, the effort is not seen. Here again, it has to occur for a minimum of 10 seconds or more. Kinestroke breathing, which we have always classically studied in medicine and very less seen or never seen, but it's an important part that it has cyclical alternating pattern where there are increase and decrease periods of breathing, which are followed by a central apnea. And here the stimulus is between hypoxia and hypercapnia that stimulates the brain in different ways and drives the respiratory system to have alternating increased and decreased periods of breathing. And this is usually seen in severe heart failure patients, those who suffer from stroke, or those who have had any central nervous system or brain injuries. The nocturnal hypoventilation syndrome, it's where there is a reduced rate and depth of breathing. So it's a shallow breathing, which occurs due to loss of muscle tone and sleep during sleep, and especially during the REM sleep. This occurs in patients who have chronic pulmonary disease or neurological impairments, restrictive diseases, or those who are obese, where the daytime effort with the muscles is too high. There is too much dependence on muscle tone, and when this dependence on muscle tone is lost, this person has a shallow breathing. Obstructive sleep apnea, the major part to understand that what is obstructive sleep apnea, it is the most common type of sleep apnea. It is usually seen in males. It is usually seen with obese males or those who have a short neck, or those who have some adenoid problems. And here we have repeated episodes of complete or partial blockage of upper respiratory airway during sleep. And here the tongue can fall and it can obstruct. But this results in awakening, slight awakening with an effort to resume breathing. The global burden, if we understand, it's very high, and we find that in patients who even in countries like India, the patients are very high. So India ranks among the fourth to have most people with obstructive sleep apnea in age of 30 to 70 years. So moderate to severe OSA is seen in almost it stands into the fourth position in world. So India has around 50 million people who have AHI or apnea hypopnea index more than 5. That means the event is occurring per hour, more than 5 events, and this is called as mild, and more than 15 is called as moderate. So moderate apnea is seen in almost 30 million people in India. And what happens here is the airway gets closed. It results in hypoxemia. It results in retention of carbon dioxide. It results in slight arousal. It opens up the airways. The person again goes into deep sleep. Again, the airway gets closed as the person goes into deep sleep, and the cycle repeats. And every time the body feels that there is a sympathetic nervous system surge, because it feels that as if someone is throttling or someone is pressing on the neck, and therefore the adrenergic system activates, the cortisol system activates. It results in increased blood pressure, increased sugar, increased heart rate, and finally sleep fragmentation. And therefore these persons are falling asleep in the day or even while they like the person I was talking about, while they are driving a scooter or handling any machine. The pathological consequences, there is because of the raised cortisol, because of the continuous sympathetic drive, these people actually have not actually had a good sleep for years together, and therefore they have an insulin resistance, which results in type 2 diabetes. They have increased blood pressure, which results in hypertension, metabolic syndrome, weight gain. And this weight gain, it cannot be brought down by any pharmacological or exercise or dietary method. It needs a treatment for OSA to bring down the weight, because this is how the cortisol at the night, it is increasing and it is causing raised weight. The behavioral, these persons remain, because they are sleep deprived, they remain irritable. They find the concentration is difficult to concentrate. They have premature aging, because there is the restoration does not happen. They remain in anxious, depressive state, and they have headaches. They have fatigue and fatigue-related accidents and excessive daytime sleepiness. Risk factor for OSA, this is a typical Pickwickian physiology or pathogeny that we described, that it's a male gender, obesity, increasing age, post-menopausal females, after their menopause, 5 to 6 years down the line, they can become equal incidence of having OSA. Alcohol or sedative use, smoking or anything which inflames the upper respiratory tract, diabetes, family history, and then genetic disorders which can have small facial bones or narrow nasal passages, this is chin, or excessive tissue in the upper airway. So all these things can affect. Sleep apnea occupies a very important part in cardiovascular diseases, and these are often overlooked and missed because we try to treat the disease or the syndrome as a primary thing, and we do not try to relate it with sleep apnea. So in drug-resistant hypertension, the chances of having sleep apnea is 80% plus. In diabetic patients who are obese, again, it's 60%. Heart failure, almost 2/3 of the patients can have sleep apnea of some kind. Maybe it may be central sleep apnea, may not be obstructive sleep apnea. Atrial fibrillation, half of these patients can have some kind of sleep apnea, and they'll be benefited just by treating with BiPAP or CPAP as is required. Coronary artery disease and angina is lesser than 30%, but then these patients will have nocturnal angina, which is seen during sleep time. So daytime and nighttime symptoms are different. Daytime can be excessive daytime sleepiness, feeling tired, lack of energy, early morning headaches, early morning not feeling that they have awoken fresh from their sleep. They can have higher blood pressure, higher sugar, higher lipids, learning difficulties, especially in children. In children, the adenoids and other swellings can be responsible for obstructive sleep apnea. Nighttime, patients can have fibrillations, patients can have arrhythmias, they can have palpitations, they can have sexual dysfunction, night sweats. Partners can witness the stoppage and start of the breathing, irregular breathing during sleep, and increased frequency of urination because of the dilated atria and the ventricles, and above all, snoring. Consequences: the estimated total economic loss for sleep disorder in country like Australia in 2012 was $808 million annually. So we can imagine, though we don't find what our older generation used to believe that snoring suggests a deep sleep and a good sleep, but it is other way around, that it's a very costly sleep that we are having. So compared to patients who are without OSA, patients with OSA, they need longer hospital stay. They have 50% more physician visits, and they cost twice the healthcare cost. Screening diagnosis now is very easy. previously it used to be that we need to send these patients to a sleep lab, proper sleep lab where 24 or so channels were analyzed. But now screening is easy because now there are devices which can be put on these patients, a single finger device which can be put on patients, which can measure one or two channels, can screen whether there is likelihood of a requirement for a detailed screening or detailed evaluation, or the patient is normal. So first of all, clinically, we need to see whether these patients do belong to the Pickwickian body, that is, they have obesity, central body obesity, male with a thick neck, the neck circumference is thick, 40 years of age, nasal obstruction because of any other reason, or any other reason for anatomy, narrowing of the nasopharynx, neurological syndromes, Down syndromes, genetic predisposition, and patients who are smokers or having any other endocrine abnormalities. There are questionnaires which have been evaluated. So there are multiple questionnaires like Epworth Sleepiness Score, Stanford Sleepiness Score, or Pittsburgh Sleep Quality, which have, but the two which stand apart is the Stop Bang questionnaire and the Berlin questionnaire. So the Stop Bang questionnaire, it works with the mnemonic Stop Bang. Stop is for, do you snore loudly? Do you often feel tired? Has anyone observed you stop breathing during sleep? And finally, do you, or the person is being treated for high blood pressure? The bang is whether the BMI is more than 35, age is more than 50, the neck circumference is more than 40, and the gender is male. So if the Stop Bang questionnaire has just for these, the scoring is done depending upon score 0 to 2, 3 to 4, and more than 5. So 0 to 2 is a low risk, 3 to 4 is an intermediate risk, and there we need to evaluate. If it is more than 5, it becomes high risk. For 3 to 4 and 5, we go to the step 2 and we analyze the stop part. Diagnosing OSA, this is the second step. There are different types of devices. Now, devices have also been typified as 1, 2, 3, and 4 type of devices. And there are proponents for sleep lab testing. Those, especially for pulmonologists, they want that their patient should spend a night at hospital in sleep lab. And there are people like us who believe that a screening home sleep test can help, and then we can refer or we can send these patients for sleep lab. So we'll briefly touch upon what these tests are, and we'll finally also touch upon one sleep test or the night out test. So type 1 is the best polysomnography or sleep test, which is done at an overnight clinic where a person has to sleep. Would be video recorded, we will have audio recordings, and everything would be observed throughout the night, and this is called as polysomnography. The type 2, 3, and 4 utilize different channels. The type 1 can utilize something like 24 channels or more. Type 2 would utilize 7 channels, type 3, 4 channels, and type 4, 3 channels. But this can be done at the comfort of patient's own house. So type 1 devices, that is full polysomnography. It includes an in-lab study, audio-visual recording, 24 channels, EEG, ophthalmograms, EMGs, ECGs, thermistors, pressure transducer, respiratory effort. So there are, the person is wired throughout, and everything is being monitored. How much limb movement happens, and is this limb movement related with the saturation, with the respiratory effort, with the body position, and the snoring. Type 2 devices, this can be in lab or in home, but it's a cut down version of PSG. It is usually without the audio visual part, but still it records snoring by catching hold of the vibration that happens in the nasal prong, and with the chest expansion, it can cause for the different movements that are happening to the person. Type 3 devices are very basic devices, and this is what is apnea link air. That is, it has 4 channels or which includes pressure, it includes a snore, respiratory effort, and SPO. Here, the data for sleep and sleep staging is not there. It is not possible. Type 4 is usually 1 or 2 channels, and mind you, this is only for screening devices. And so anxious patient, where if we send these patients to lab, it becomes difficult because sometimes the test is not fruitful. It doesn't bear fruits because spending a night away from home can be stressful. Having a medical diagnostic test is stressful, and having the feeling that someone is watching while you are sleeping, it can also result in a poor sleep study, poor sleep. The polysomnograph, it has from tip to toe movement of eye, EEGs, EMGs, ECGs, air flows, nasal pressure transducers, the chest movement, the abdominal movement, oximetry sensors, snore microphone, body positioning, how the legs are moving, and so. So all these things are measured, they are recorded, and they are done. It starts with a calibration that is often required for it's like the supine and deep breathing during treadmill test that we do. So that is calibration is done, and then it gives us a constructed sleep structure which is called as hypnogram. So it depicts graphically the organization of the sleep during night. Each stage of sleep is characterized by a level on the vertical axis of the graph with the time of the night on the horizontal graph. So what is the stage? Stage 1, 2, 3, 4, REM, and then wakeful and movement. And the dark bar is considered to be the REM sleep. So REM is always mentioned or highlighted with a dark bar. So with different stages of sleep, that different changes happen in EEG. Alert wakefulness, it starts with the beta type of waves in the EEG, which are fast and have a higher cycle length. There, that it gives 13 CPS per cycles per second. They are low voltage, random pattern with few rhythmic components. The relaxed wakefulness, again low voltage, rhythmic alpha pattern with occasional bursts of alertness. And here the cycle per seconds they decrease. In the N1, it becomes theta waves, which are still lower cycle. Theta waves, they again have some alpha waves in between. N2, primarily theta waves with sleep spindles or the K complexes. And here the amplitude increases. Till now we had a low voltage, but now we have a voltage which increases, and they have 12 to 14 lasting around 0.5 seconds to 1 second, slow waves, but with high amplitude. Till now we had fast waves but low amplitude. Now it becomes slow waves but high amplitude. And in N3, slow waves or the deep sleep, delta waves come, and here we have lesser than 4 cycles per second, high amplitude, again low waves with high amplitude. REM, here it is N1, that is, it has sawtooth wave. It is again low voltage but very fast, and here it is seen with the eye movements and respiratory and cardiac irregularities, that the autonomic system activity or some sympathetic drive kind of thing is happening. So these patients, when we do the stage wake cycle, the person becomes drowsy. This is how it changes. We see more of alpha waves, and they gradually become slower and slower. The cycle per second, it decreases. In obstructive hypoapnea, there is decrease in chest and abdominal movements during hypoapnea, and this distinguishes it from the apneic, where there is no movement during during the apneic period. And the chest and abdomen, the thoracoabdominal respiration, it changes, it becomes paradoxical, and the chest comes first and then comes abdomen. That is what happens in obstructive apneic stage. In apneic stage, the obstructive apnea, the airflow totally ceases, and therefore we see a straight line which comes in the thoracic movement, in the nasal, or in the abdominal movement. And here the saturation, it comes down, and we find that it correlates well with the loss of movements in the abdominal and the thoracic muscles. In the mixed apnea, it's a combination of both, where there is an initial central portion during which there is no inspiratory effort. It is followed by an obstructive portion, and then paradoxical chest and abdomen movements. The small fluctuations in the chest and abdomen, they happen, but here which they are happening just prior to the larger fluctuations are probably because of the chest and the cardiac movements. The type 2 devices which I commonly use in my patients is it monitors, though this is even not the one that I use. This allows for sleep staging, measurement of total sleep time, and it is a short version of the type 1. The type 3 devices is the one that I commonly use, and this is tied with a flexible tube on the chest of the patient. So as the chest expands and it comes in, the movement is recorded. There are nasal prongs which are put on patient's nose. However, so it records the respiratory movements, it records the airflow, it records the SpO2, but it does not record the EEG, and therefore stages of sleep we may not be able to define the stages of sleep. So this is one typical person who has 5-channel recording, that is, he has a nasal flow recording, a chest band that expands or moves with the respiratory effort. So respiratory effort is recorded, SpO2 looks for saturation and pulse, and the snoring part is derived from the nasal prong itself, which is derived from the nasal flow. So this is how it is seen in sleep disturbed breathing. The normal pattern is where the breathing is a sine wave. Hypoventilation happens when this has reduced more than 30% of the normal. So a reduction in this sine wave amplitude more than 30%. The flow becomes limited, it forms a plateau. The snoring results in these vibrations in the nasal flow, and hypoapnea and apnea would be a straight line. Hypoapnea will be further reduction. So flow limitation, where upper way narrowing happens, and this is the earliest sign of impending upper way closure. Hypoapnea is when the more than 30% reduction in airflow lasts, mandatorily lasting for 10 seconds or more, and again 3% or 4%, that their guidelines are different, but at least 3% reduction in oxygen saturation from the baseline. And apnea is cessation of airflow more than 10 seconds. The severity of apnea is based on the total number of hypoapneas and apneas, that is the cessation of breathing or partial obstruction within 1 hour. So it can be of 3 types. It can be obstructive, where patient is trying to breathe but does not get air; central, where the patient is not trying to breathe and does not get air; and mixed, when there initially patient does not make effort, but when efforts resume, the patient is still not able to breathe and has apnea which is continued. Scoring of apneas has been evolved over time. So 2007, the guidelines suggested that the peak thermal sensor exclusion by more than 90%, duration of event lasting 10 seconds, and at least 90% of the event's duration meet the amplitude reduction, that is 30% criteria for hypopnea and apnea. In 2012, there was the thermal part was replaced by the oronasal airflow, where and the duration of 90% drop more than 10 seconds. And obstructive apnea should be an apnea with continued and increased respiratory effort, that it should be followed by increased respiratory effort. Again, scoring of hypoapneas, initially it was 4% oxygen desaturation in 2007. Oronasal airflow decreased more than 30% from the baseline, and a more than 30% drop in signal exclusion, and this should be mandatorily more than 10 seconds, or a decrease more than 50% from the baseline lasting more than 10 seconds, and a 3% oxygen desaturation. But in 2012, it all changed to 30% and 3% for defining hypoapnea. The classical hypoapneas, those which have reduction in more than 30% decrease in airflow without requirement of any associated oxygen saturation or arousal. So anything which has a decrease more than 50, and or it should be lesser airflow reduction, but it is associated with a significant, that is more than 3% decrease in oxygen saturation or arousal. AHI is a combination of these. So hypoapnea index. So it tells us the number of apneas and hypoapneas that occur during sleep, 1 hour of sleep. So mild is between 5 and 15, moderate is between 15 and 30, and anything above 30 becomes severe. Central apnea is when there are no respiratory efforts throughout the entire duration of the event, and it lasts more than 10 seconds. Type 4 devices are the ones which have come recently, around 3 years. They are into use, and they use only, these are primarily for screening. So they do not give us much information, but it's like CT coronary angiography. If that is normal, it assures you that the person, so they come with a high negative predictive value. If these devices do not pick up anything abnormal, then the likelihood of person being normal is high. But if they pick up, then we have to subject these patients for further the type 1, 2, or 3 devices study. So here single parameter or 2 parameters are taken, either oxygen saturation or airflow, or both of them are done. And again, the same way, the number of events, the drop in saturation lesser than 90, lesser than 80 or 85, they are taken, and we define OSA based on the number of events. If they are more, if it is lesser than 85, it becomes moderate. If it is lesser than 80, it becomes severe. So this is a single device, very easy to use. It's tied to the index finger of the person and connected to the person's Bluetooth mobile, and it weighs very small. It does not disturb. It can be done at person's place. Only a wireless connection is required with a smartphone, and the smartphone does all the recording through this. And it has been validated by the American Association for Sleep Medicine, and but it has been, again, I'll stress it again, that it is validated for screening and not as a full sonography test. So night owl system, it enables us that it can derive the diagnostic parameters that the manual recommends for scoring the sleep and associated events, and it also utilizes the peripheral arterial tonometry. So this is a new addition to the understanding, and so it utilizes the 4 channels, that is the peripheral arterial tonometry, pulse rate, oximetry, and the actigraph. So it has an accelerometer kind of thing which records the limb movements of of the person who's being studied. And therefore, it combines all these things into recognizing that whether this person is having, say, like vasoconstriction, which is manifested as a PAT, peripheral arterial tonometry decrease. If it coincides with oxygen desaturation and a pulse rate increase, it is marked as an event apnea or hypoapnea event. So it is approved. It has been validated by many places. Many studies have done, and it has shown that the routine somnography or polysomnography test, it compares very well for comparison. It is now in recommendations, strong recommendations for screening in those patients who are well informed, who are educated, and you need to tell them that there are other modalities also available, like the polysomnography test or home sleep assessment test. And this is one of those, and this is limited to screening. So strength of this test is that it is accurate. It can be utilized for 1 night, 2 nights, 3 nights with the same device, high patient comfort in his own comfortable house. Limitations that it does not record a direct respiratory effort. So we cannot discriminate between central apneas and different other types of apnea. It does not give the EEG-based sleep stages, and it does not give apnea or hypoapnea discrimination. So it remains only good for a screening test. Once this is positive, we can subject these patients to the other test. Coming to the management part, obstructive sleep apnea, it starts with, as always, with lifestyle changes, desire to reduce the chin fat, a desire to reduce weight, overall weight. So weight reduction, trying to sleep on sides. So sometimes we advise the patient to put a tennis ball into his night shirt, so that whenever he lies flat and the tongue is falling, the tennis ball would pinch him, and he'll take turn a lateral decubitus position so that he can have that tongue falling out. Avoiding alcohol, because alcohol is, again, it results in more laxed upper respiratory tract. Avoiding smoking, because that inflames the upper respiratory tracts and makes it more prone to these devices. There are mandibular repositioning devices, or there are even surgeries which reposition actually to keep these airways patent during night while the patient is sleeping. There are other computer-aided designs which enable very high customized treatment for these patients. So they are precisely fit, they have a comfort retention, and these can keep the upper respiratory patent while the patient is sleeping. Then the pressure, continuous pressure airway, continuous positive pressure airway, or CPAP, and this works as an air sprint, because here there is slight pressure which is attached. It varies from 4 or 5 millimeter Hg to 19 or 20 millimeters Hg, and it keeps by forcing in the air, it keeps the airway patent, and it becomes very easy to use and non-invasive therapy for these patients. It can be given through a nasal prong, which it gets fitted, plugged very snugly into the nose, or it can have a nose plus a mouth mask, or it can have a full face mask, depending upon the comfort of the patient. So this is how, when we treat OSA, we have to understand that this is the upper respiratory tract, the tongue, it is falling into the respiratory tract, making it narrow. And so we have to find a way to keep this airway open, either by using the customized computerized implants, or through keeping it, using the air to keep it open. So there are again two varieties. One is fixed CPAP, which gives a constant pressure level throughout the night. But we know that the sleep, during sleep, the pressure and all those things change the lung parameters and the aspirations, and therefore it has to be a variable. So there are auto set technologies which can change which can use algorithms for determining what is the requirement by the airflow movement in the throughout the pipe and the machine, and it can adjust these when it can have high pressure during inhalation, and it can lower the pressure during exhalation, so that exhalation is facilitated. And also it has openings where through which the carbon dioxide can escape out, and it does not result in a rebreathing of the carbon dioxide in the same patient during night. Then we can have automatic air pressure, positive air pressures, APAP, which again uses algorithms to deliver different pressures throughout night, where at the initial moment, in the initial hours of sleep, the pressure requirement is less. Once the person goes into deep sleep, the pressure requirement increases, and so the pressure to keep the airway patent increases, and again in the morning we find towards the morning it decreases. Until unless the person has so these are the patients who can benefit from these such kind of things. So if HI is more than 15, that is, if it is severe, then the PAP is the first choice. If HI is between 5 and 15, then PAP may not be the choice for everyone. It may be choice for a few. We have to again understand that everyone is not comfortable on these machines, but people do find them addictive once they, after years of non-sleeping or not sleeping properly, they get a good sleep, they become addicted to this. So there can be reasons where patient is uncomfortable. It can be mask leaks, the mask is not snugly fitted. It can be dryness. So these machines come with a water reservoir to make the air dry, which avoids the rhinitis or congestion part. It needs some motivation in early part, but later on these patients become kind of addicted to it. And the pressure discomfort or hard to exhale, there are again the uses of algorithms which can have that auto set thing, APAP thing into this. So greater adherence is required where patient has severe OSAs, morbid illnesses. These patients some may prefer a nasal prong, some may prefer a face mask, or some may prefer a total face mask. Non-compliance is usually because of the ineffective treatment, because if the treatment becomes ineffective, the patient do not even for their daytime sleep also insist that they want to use this machine. And finally, the difference between auto set and non-auto set, it becomes economically viable for auto set because of, if we consider that these patients with their increasing comorbidities, diabetes, heart failures, hypertension, diabetes, and renal failures, would land up with more cost rather than lesser cost. So these patients should be picked up early, put on treatment early, and should be counseled to use these machines. And we should take out time to find out what is causing a non-adherence in these patients. So compliance is defined as the CPAP should be used for more than 4 hours per night on more than 70% nights. So a person should be using it around 24 to 25 days in a month for more than 4 hours in a day. So the ways to ensure compliance is patient education, particular mask, the trial of different masks, humidification, and then again now these devices are connected to the person's mobile and they can send data to the physician. So you can adhere, or you can monitor your patient's data daily if you with a simple software installed in your laptop, desktop, or even on your mobile. So this results in a connected care where there is remote monitoring is possible. It can tell you how much patient has used, whether it was fit, the mask was fit, or it was not fit. Even the display comes when the patient unplugs in the morning. The display comes that with a smiley. So if there was no leak, it was perfect fit and good AHI values, then it would have a smiley face. If it is not, it will have a frowning face. So this is how I use it, that I have this software installed. I have my patients who can send with their consent, they can send through their mobile the data to me, and it is time to time, it is analyzed. When they come to my clinic visit, I analyze there. And this is how it comes around, that it comes with a patient name and how much they have used, which date they have used it well, which date they have not used it well. Sometimes the person is traveling, so, or all those things, they come and it can tell us how to use it. So, and there are number of studies which prove that this is beneficial for our patients. I will not go into that. We understand that this is going to be beneficial for those patients who have sleep apnea of different kinds, and this therefore they can have a shortened life, something like 6 to 7 years shortened life if person is suffering from hypoapnea or OSAs. So I thank, and I again we can have questions if there are any. Hi Nikhil. Hi Jay. You are muted. Both are muted.
Yeah, great presentation, Dr. Smith, on often underdiagnosed problem. And you made a very comprehensive and elaborate presentation too.
So it all started with a patient that I had maybe 20 years back.
Points.
He was a doctor in our hospital, medical college, and he was undergoing a renal angiography for his uncontrolled hypertension. And every time he was put on CAT table, his BP shot to 250, 150 kind of thing. So then he consulted me, and I told that you have got with central obesity and everything. So that time, he took it as a joke. So he consulted my professor in medicine. He said, "ये नए लड़के आते हैं, कुछ भी ideas लेके आते हैं." 2 years later, he went to Nagpur, to another city, to consult a nephrologist, whether this hypertension is because of some kidney disorder. The nephrologist told him, "You go and consult a pulmonologist first, then come to me." From his clinic, he rang me. Here he is saying the same thing, that I should get a sleep study done. After getting sleep study, he lost almost around 24 to 28 kgs of weight with using of Viper.
Alok,
Night owl device is available here?
The night owl?
Yeah.
Night owl is available. It is available in India for last 2 years.
We have only seen that the test that we do at home sleep test. We have not seen that pulse oximeter test.
Night owl is easy. It's like if you want to rule out, the thing is that I find it is not that obese person. Lean person also have now obstructive sleep apnea, particularly in a polluted place like Raipur.
Actually, where people are not very don't understand this problem. Yes. You will tell them the sleep test, they will not believe you. The test must be simple test. Like this home sleep test is very nice. It can be kept done at home also. And then problem starts, and you just give a trial for CPAP trial. Then they think the magic is there. They will remain awake for 3 to 4 days, and after 3 to 4 days they come and now I want that machine.
So in fact,
symptoms get relieved for 3 to 4 days. So that CPAP trial is very important.
what
After
I
the
do is
CPAP
that
trial, then only they believe.
I advise the person to do half night test and then half night a trial. So it comes with 2 AHIs. One AHI is for the test and other AHI is for trial of the mask.
After the trial.
Then you can show them that numerically, the person had 24 AHI and after use it came down to 6.
After that, they have marked improvement in symptoms
Yes.
also. They remain awake. Their number of medicines for the blood pressure goes down. Many things improved after that. Their quality of life is much better after that. Hi, Jay sir.
Hi, Alok. Yeah, happy birthday. I forgot to wish.
Thank you, sir. We have spent much of the MD and DM time with Jay sir.
Dr. Smith, what about the lean people? Do you find many people who are not fitting the classical Pickwickian morphology who still present with OSA?
Yes, I do find.
What about central sleep apnea? Have you managed to pick up any patients with such?
I have picked up a few who had both. And that was the one example I gave. The person had 2 accidents driving a scooter. He fell asleep while driving a scooter. So he came to my clinic. In the waiting room, he slept. Talking to me, he was nearly, drowsy. You have to ask him, you have to shake him. And then when I asked him to get this test done, so he said, in my caste, we barely live till 40, 45. I am 52. So don't ask me to spend any money.
Hi, Nikhil.
So I think next would be class on MRI, interpretation of cardiac MRI by Dr. Y. Chandrasekhar.
Okay.
So next fourth Friday, and that. So I think we can call it day and let Alok enjoy his birthday. तो अभी केक काट लिया कि भी बचा है?
क्या केक काटेंगे हम लोग सर? छुप के मजा लेंगे आज. हम लोग तो छुप के मजा लेते हैं यहाँ पे. मजा लेके बस सो जाते हैं.
आलोक बहुत बहुत बधाई हो बर्थडे की. बहुत
अच्छे. थैंक यू सर.
आप तो पटना में जाके गायब हो गए.
अच्छा, जुलाई में आ रहे हैं कि नहीं चंडीगढ़?
चंडीगढ़ किस लिए आ जाएंगे बोलिए?
बाली सर करा रहे हैं ना 8 और 9 जुलाई.
अच्छा,
आइए फिर से घूमते हैं.
फिर से दारू पीते हैं. जलंधर में जाके.
चलिए सर.
ठीक. ओके.
चलिए बहुत बढ़िया.
Nikhil, nice to see you, man.
Yeah, same Jay.
Nikhil sir looks the same now. Nikhil sir वैसे ही लग रहा है अभी.
नहीं, थोड़े से बाल कम हो गए हैं.
He looks like a real mature cardiologist.
सही है.
चलो
मिलते हैं फिर.
Yeah. Good night.
Bye.